Hello everybody, it's Dr. Galvin with the coronavirus update for today. Today's Monday, the 27th of April. Gonna be short tonight. I'm actually working in the emergency department tonight, and so I'll be back probably in the morning with a update of what things are like in the hospital these days here in North Carolina. Usually some interesting information at the end of one of these night shifts. Normally, shift goes from 8 to 6, but because of cutbacks in staffing and hours, it's a 10 p.m. to 6 a.m. shift. And I'm single coverage, which kind of sucks. As an ER doctor, if you work in a busy place, and our emergency department sees 50 to 60,000 patients a year, we don't like to run that place with only a single doctor. But because of staffing cuts, because of volume drops, because of the virus, we're now down to single coverage from, physician-wise, I think from 11 o'clock to 6 a.m. or something like that. So it's a little bit lonely there at night, but hopefully everything will be fine tonight. And I'll give you an update tomorrow. Numbers today, 3,050,000 cases, I think, worldwide, 211,000 deaths, 917,000 recoveries. In the US, we're a little over 1 million positive cases, 56,000 deaths, 137,000 recoveries. Of note, 5.4 million tests done. That's according to Johns Hopkins. I'm assuming that means, tests for people who are sick and getting tested, not antibody tests. They don't really tease that out, but we've talked about the importance of this testing in order to get us all back to normal, and that's a key thing. I'll come back to that. Lots of conspiracy theories out there. I get it. We're getting frustrated. We are stuck in our houses. We have nothing to do but browse the internet, but a lot of this stuff that people are reporting, conspiracies and everything else, if you really look at it, much of it doesn't play out. I think the one I keep getting a ton of information about is that we're cooking the books about cases. And somebody posted on our Facebook page today the CDC, where it says, if it's a presumed case, you can call one of the secondary diagnoses presumptive COVID. And that's proof that there's this conspiracy. No, it's not. When you say something's presumptive, you say, listen, I suspect it. It's a little, this person died of respiratory failure. They had these things going on. We don't really know exactly what happened, but it was suspicious for this, so we're going to call it presumptive. The CARES Act does give the hospitals a 20% boost in reimbursement if COVID is part of the diagnosis. And the CDC has said if it's a case that looks like, if it looks like a duck and it smells like a duck, we're going to let you call it a duck, even though we don't know 100% sure for sure it's a duck. However, if you come in with a heart attack, you can't be called COVID. You can't call that presumed COVID. So these are people that come in with fevers, respiratory difficulties, things that you would suspect that it's probably a pneumonia or something along those lines. And when they die, if they die before they get tested, the hospitals are allowed to say, COVID's a possibility and get that extra money. So it's not that there's not extra money there. The reason it's in the CARES Act is because hospitals are bleeding money. And the implication from somebody that posted today was that, the hospitals are doing this to, make all this extra money. No, the hospitals are bleeding money. Hospitals make their money from elective procedures, which have been completely canceled. The reason that my emergency department shift is short tonight and why all my staff is getting cut and why all the staff in the hospitals are getting furloughed is not because the hospitals are making money hand over fist. That money is in the CARES Act to try to keep these hospitals afloat. Smaller hospitals are going to end up closing. And do you want your community hospital to close because of this outbreak? So I think you need to look into this data a little bit more carefully. There's not a global conspiracy to upcode these things. No one's come to me and said, Dr. Galvin, you need to change the diagnosis here to COVID. That's absolutely not happening. The next thing I want to talk about was a couple interesting articles that are showing excessive death rates. And that's what New York City did. They saw, there's a predictable amount of death that happens on average each month of the year. And that's what insurance companies rely on, this actuarial data. So you can kind of guess what's going to happen within some range. But when you have sudden excesses by very many by multiple times of deaths in a particular period of time, you got to attribute it to something. And that's what we're starting to see. There's a preliminary study out, not peer reviewed, that essentially looks at the time frame, I think, between March and April, and shows that there's actually quite a few deaths in the US that are unexplained. excess deaths that weren't diagnosed with COVID, but excessive deaths. And you know, a lot of people, a lot of the EMS systems are reporting really big increases of people dying at home. And if someone dies at home, you know, we may not know whatever. You know, if the family doesn't want to do an autopsy, it's somebody who's older, maybe has some underlying medical problems. They get called out there, and you know, the medical examiner doesn't usually do autopsies on that people. So there may be that we're underestimating the deaths. Again, until we get testing, it's so difficult to talk about it. I talked about this Dr. Erickson in California, and you know, I'm not saying that these guys aren't smart, but what I am saying in my rebuttal to that is that they are taking the percentage of positive cases from their clinics and from California as a state and extrapolating that to the entire population. We only test sick people for COVID. Remember, COVID testing is very limited. Even today, it's hard to get. And there are pretty strict guidelines who you check. You know, if someone comes in with a cut on their finger, we don't do a COVID test on them. If you come in with fever and cough and things like that, we do. And so people that are coming into these clinics with those types of symptoms, fever, cough, you know, runny nose, diarrhea, those people are getting tested, and 12% in California and 6% in Dr. Erickson's clinics are coming up positive. But those are sick people. That's selecting for sick people. You can't go around and say, okay, if 6% of the sick people that we have these symptoms that are like COVID, then it must mean that 6% of people who don't have any symptoms have it as well. And that's an intellectual leap that doesn't really bear out. Now, are they right? Are they wrong? The only way we'll know is by more testing. So the more testing we get, good antibody testing, then we'll be able to get a picture of what the real numbers are. As I've been saying from day one, your individual risk of dying from this virus are extremely low. The vast majority of us are going to get, if we get sick with it, we're going to have a flu-like illness. It's going to last for a week to 10 days, and then we're going to be fine. So, you know, the social distancing, I think we may be getting to a point where we can really sort of start backing off on it if the data supports it. But, you know, we can't, you know, if we get this wrong, we could potentially kill hundreds of thousands of people. It could be a person from every family in the U.S. And, you know, are you willing to take the risk by jumping, you know, to conclusions? Remember, it doesn't matter how much we want something to be true. It doesn't make it true. What makes it true is seeing data and being able to use that data to inform our decisions. The data is coming, and I think that, you know, we may well be able to quickly ramp things down if the data is kind of trending like we've sort of seen with these antibody tests in New York. But again, we need legitimate testing. A lot of these antibody tests are very, very suspect. So remember, the market is getting flooded with these people trying to make a buck, and we don't know if these tests are good. But there are certainly some of the bigger companies like LabCorp and things like that that can do this sort of backup testing and say, oh, you know, we know these people have it. Oh, we did these tests. And, you know, once we have validated tests, and we're going to have them validated independently and individually, each one of these tests, to know for sure that they're working. But once we have that data, we'll be able to make some changes. I'm going to stop here. One thing I did want to bring up, it looks like they're looking at utilizing famotidine or Pepcid, possibly in conjunction with hydrochloroquine. There's a study ongoing, I believe, in New York. They haven't reported any data yet, but there's some interesting, early on I heard something about Zantac, and I'm not exactly sure what the mechanism, but somehow those H2 blockers have some effect on viral replication and may have, you know, may be beneficial in some form for the virus. So we'll know more once those more tests come out. I will talk to you guys tomorrow morning after my shift in the emergency department tonight. Wash your hands, take care of yourselves, take care of those around you, take care of your families, and I'll talk to you in the morning. See ya.